All right, thank you. Let me get this slideshow up. And
I do have it up if you want me to share slides for you, Marina, or you can go ahead and get started.
can you see it?
Yes.
Okay, perfect. Okay, so as was mentioned, this is I'm Marina Works. I'm one of the ECHO team members, and I'm here with Gerald Ackerman, and we're going to present this slide. And Dr. John Packham couldn't be with us today. This is one that him and Gerald, I think, had initially developed, and we updated it for this presentation today. And with that, I am going to let Gerald take it over. We're going to do just a quick update of rural and frontier Nevada and how the SORH roles in building rural public health services capacity. We're going to talk about public health versus population health, organization of public health in Nevada, rural public health issues with COVID, and a case study of Churchill County and our lessons learned.
So thank you, Marina. And Marina and I were both just in Eureka County yesterday. And so part of what we'll talk about, she'll visit with you about. But, you know, oftentimes when we think of healthcare forever in rural Nevada, we've always thought of, you know, hospitals, community health centers, rural health clinics, tribal clinics, VA clinics, and this is just a map. And one of the things I'd point you out to is, especially for any of our urban counterparts, if you go to the Office of Statewide Initiatives and type in Frontier Rural Nevada Data Book, all of these charts and tables, anything you could possibly ever want to know about rural Nevada, and some urban facts are in that chart and data book. And there's quite a few other things. But one of the things you'll notice about Nevada is frontier. It's not rural, it's frontier. And so when we talk to our colleagues around the country, we always like to point this out, that yes, we do have rural portions of urban counties too. But, you know, Nevada is always considered an urban state, and that's because of our two population centers of Las Vegas and those areas around Washoe and Carson City. But we're frontier, and frontier is that amount of population per square mile. So you can go ahead with the next slide, because I think I need to move along here to give Marina enough time to work.
I'm working it. Hang on. For some reason, it didn't advance. Sorry. There we go. Okay.
But I think one of the things that COVID brought on to us, that rural or the healthcare is not just hospitals, clinics, doctors, and nurses. We've all become acutely aware that it's also public health. And you know, there's lots of ways to look at rural. One of them is called a RUCA, and I don't know how many of you have heard of RUCA scores before, but it's a United States Department of Agriculture. And what it is it's a rural urban commuting area codes. In other words, how far you're traveling to get to an urban area. And so if you look at that, we've got a lot of dark blue on there. That's what this kind of is, a lot of light blue, you know, and then we go down the color scale. And so we really have to travel a long ways for anything. And I think one of the things that was brought out through this COVID pandemic and through other public health emergencies we have, to get anything done in our state, we appreciate, you know, our infectious disease docs. But if you live in Elko County, where I live, we're 7 hours away by a car drive, and we have one flight a day coming into the community. We're one of the lucky communities. You know, if you're in Eureka or some of those other counties or other cities, you don't even have the luxury of having that one flight a day come in. Go ahead, next slide. This is just another way to show you what sources are there. Urban hospital service areas. These are just kind of the hospital service areas that we broke out, and where these rural hospitals serve. As you can see, there's a lot of, you know, lined area. Lots of that is to do with, you know, no population areas there, but, you know, we have people and ranchers and all those things all through those areas. And so we've got a lot of area that doesn't have coverage sometimes. Keep going. All righty. You know, one of the things I learned, I came from rural Idaho 32 or 3 years ago. If you ask anybody how far it is in rural Nevada, they never answer you in miles, do they? They answer you in how long it takes to drive. You know, once they increase the speed limit to 80 miles an hour, it kind of threw me off for a little while because it decreased my travel time. But we have a long way between communities, and oftentimes we tell people, why is that? Well, we have communities either where somebody found gold or silver and they started a town there and the town happened to survive. But if you look along I-80, why do we have communities every hour? You know, there's about a community every hour. And the reason is the railroad. They had to have a place to fill the trains full of water. And so they had railroad stops. And that's where a lot of our history comes along too. So you look at those mileage charts, it's a long ways. Go ahead. And then this is just a map that shows the mileage and interstate highways. And one of the things I like to point out with this map is that it's always interesting to me that you have I-80, you have 93, all of our rural hospitals get to see the same trauma and car accidents that our urban centers get to see because of what goes through their county. And so issues such as trauma, issues such as, transient populations and things like that, our rural communities are impacted just as much as our urban communities because of the transportation that goes through those. Keep going. And then the other thing that I always like to point out, especially with those on our call who may be from urban and who haven't traveled out to rural Nevada, one of the things you don't understand about rural Nevada is we are the most mountainous state in the country. We have 17 major mountain ranges within the state of Nevada. So a lot of we go all the way from the lows of Death Valley and up to the peaks of where I live, the Ruby Mountains, which are 10 to 11,000 feet. So lots of different types of terrain and topography. So and weather. This is always our, go ahead, you can go back to that last slide.
Oh, sorry.
This is always the one that we like to show all of our friends is distances. We always like this slide when we go back and visit with our friends on the East Coast. You know, you can fit all of those New England states in the state of Nevada and still have room to spare. We could probably still drop Hawaii and a couple of other small states in there. We just have a lot of distance, which creates a lot of challenges, which leads us kind of where we're at when we come in and Marina talks about things. Delivering public health services in our state has always been a challenge, and delivering primary and tertiary care within our state is a challenge. But public health becomes a greater challenge just because of that time and distance. Things such as that we've learned about testing, getting results back, all those things, which are projects that we're working on right now, really become a challenge. Go ahead, Marina. So over our State Office of Rural Health was started in the 70s. We have a 30-year participating in health planning, rural population management, health management, related policy efforts. We participate in local public health associations. We participate in the county health rankings and roadmaps projects. We do have some things. We have a flex supported community health needs assessment that our office does with our local communities that have critical access hospitals. For those of you who do not know what a critical access hospital, it's a small rural hospital that's under 25 beds and limits some of its services and times of stay, which during COVID created a big problem. You're supposed to have an average limit of 96 hours. That was all thrown out the window, because we couldn't get patients out of into our urban hospitals. We participated in grant-funded cross-jurisdictional sharing and public health projects, which was happening before COVID hit. And go to the next slide, Marina.
Sorry.
Oh. So This hands it off to Marina, where she can visit about this. And this is where the State Office of Rural Health has gotten involved a lot in public health and rural public health development. And so Marina, I'll hand it off to you and you can talk about public health and what we're doing there.
Okay, perfect. So, public health is such a broad term. And I think over the last, especially 20 years, it's really gotten confused with population health management as that term has grown in popularity as well. So I just want to take a minute and define the two. So public health really is referring to that organized measure of public and private efforts that prevent disease, injury, and disability, and also that promotes physical and mental health, and really looking at that as a population as a whole. When you talk about population health management, it's really a subset of public health, and it really looks at outcomes of individuals and including how that the distribution of such outcomes within a particular group. So for example, it could be the steps a healthcare organization takes to improve the health outcomes of a defined group of individuals, or it could be how a health district might concentrate on activities of attendees at a senior center to improve their mobility. It could also be things like in a health plan, it could be all the participants in a health plan, or again, it could be just a piece of the participants in a health plan, or in a community, it could be the health of a particular zip code as an example. So kind of the difference between the two, they've been used interchangeably, but really they do have distinct meanings of each other, but they fit inside of one another. So again, just to kind of go through public health and clinical medicine. So public health being very global, clinical medicine focused on the individual. Public health has as its discipline epidemiology, economics, behavioral health, environmental health. And clinical medicine, you're looking at medicine, nursing, and allied health professionals, and really primary care, and then the specialties as well. Training, public health does usually through a school of public health or government or business, and clinical medicine goes through school of medicine, nursing, pharmacy. Team approach, public health is very multidisciplinary, where clinical medicine tends to be interprofessional, although I think we're seeing some of that change with clinical medicine looking more at social determinants of health for sure. Intervenes on public health, very much looking upstream, and clinical medicine, just by its nature and the way it's been in the United States, has really established on diseases. The best practices are defined by in public health scientific evidence encoded in regulations, a lot of regulations that deal with public health and guidelines, where clinical medicine is evidence-based algorithms and clinical acumen. Finances, public health depends heavily on grants, usually national grants, but they could be regional, local, and nonprofits and charity organizations as well, where clinical medicine could be financed by governments, but insurance certainly is very big, and out-of-pocket payments by patients. Orientation, public health, very preventative. Clinical medicine, I think, would like to be more preventative than they are, but they definitely deal with prevention, disease management, or both. And then outcomes, public health looking at reductions in exposure, disease incidence, or mortality. Public health really looks at life expectancy and how that can be improved, where clinical medicine has a lot of focus on disease management. Another picture kind of showing the same thing, where you've got the bigger picture of public health kind of enveloped within the healthcare system and within clinical medicine, because public health is also looking, because it's so much broader, is looking not just at the health of a community. Well, they're looking at the health of community, but they're also taking into account what's the water like, what's sanitation, housing, all that type of stuff that, again, as I mentioned, is becoming more and more to the forefront, as even insurance companies are wanting to know how medicine as a whole can look at social determinants. So anyway, I like this picture because it really kind of shows how that public health envelops everything we do within ourselves, within a community, within any kind of system. The public health system is really known for being that core agency within a community, kind of the ones that are connecting together the different agencies. And this is really important. And one of the things we're missing in rural Nevada, because it's helping to number one, not duplicate services, but making sure we all understand and talk to each other and know what's available within a community, and also where the gaps are. And so by bringing all these agencies together and having a hub that is helping that communication is where you can really focus and then come across where we need to concentrate our efforts. So in Nevada, we have actually 2 health districts and 1 local health authority. So there's a Southern Nevada Health District, so Washoe County Health District, and then there's Carson City Health and Human Services, which is what we call it a local public health authority. They are not a district. They don't have quite as much legal authority as a district health department has. They do have some agreements with 3 of the counties surrounding them, Douglas, Lyon, and Story. And they do some work in those counties as well. Then the rest of Nevada is overseen by the Nevada Division of Public and Behavioral Health, where they have in some counties, not every county, they have a community health nursing program. They do environmental health services, and they do epidemiology and disease surveillance, all of this happening out of their hub, which is in Carson City. So again, thinking about Gerald's slides on time and distance, they're very far away from their service areas. So we have been working with 4 counties that are very interested in developing a health district. And this is a map showing the health districts, and the proposed one you can see with Pershing, Churchill, Mineral, and Eureka County is where we're proposing to develop a health district in the rurals. So how is administration of public health handled in Nevada? We have the state administration, which is a 7-member governor-appointed state board of health. They are actually supreme in all public health matters within the state. And they really focus on the preservation of the health and lives of the citizens of the state. Then we have local administration. We have county boards of health that by statute, every county is supposed to stand up their board of health, which consists of the county commissioners, the addition of a sheriff, and a county health officer. In Nevada, that does not need to be a physician, except in Clark County. It is somebody who has training. It's supposed to be somebody who has training in public health. It can be a physician, does not have to be. And then district boards of health, they are made up just a little bit differently. They dissolve the county board of health when a district forms. And it's 2 members from each county, city, or town which participated in developing the district or establishing the district. And they're appointed by those commissioners of each of those counties that joined in. And then an additional physician who's licensed to practice in the state of Nevada. So what happened in the pandemic? Some of the rural and frontier counties had non-functioning boards of health and unappointed health officer positions. Some of them that had functioning boards of health were better equipped for the pandemic response, but there was a lot of, they had poor understanding of local, state, and federal roles and responsibilities in public health services and pandemic response. There was a lack of communication and poor coordination between local and state public health authorities, and strained relationships between rural county commissioners and rural hospitals and health systems. And just to point out really quick, I know our time's kind of short, but what happened in a lot of these counties is because we didn't have public health professionals, that either the county manager or the social services director ended up taking the role of what would have been, say, a health director or a health officer, because a lot of the health officers did step up, but we also saw a lot of them resign because really their roles in a county were very minimal before COVID. When COVID hit, they were really being drawn upon, and they were also put in a very hot political light. So we saw a great resignation of rural health officers. So case study, we have been working with Churchill County. Churchill County has had for probably about 10, 11 years now, a well-established board of health and a longstanding health officer who's a physician employed by a local critical access hospital. Churchill County has participated in cross-jurisdictional sharing projects, and they have been public health champions on the Churchill County commissioners and in their county government. They've been a recipient of CDC grants and the CARES Act, and they've really worked to build this. In fact, they are getting ready to open within probably the next month or two a satellite public health lab in Fallon. And they're really grasping to be the core of this new health district that we're working on establishing. So this, I know, is a very busy slide and difficult to read. There is a student working with John and Gerald and I on this project to help develop a playbook for how do you start a health department or a district health department in Nevada. And this is a poster that she put together to kind of delineate the steps that we're working on and what we've learned so far and where we're going with this. So lessons learned. Gerald, do you want to talk about this?
Sure. So we've brought Marina along. She's working with us now, and we appreciate. That's through a partnership with Churchill County and those 3 counties, and things are moving forward. So the SOAR is here to work on all health issues. That's our mandate through the legislature. And we're here to provide outreach and technical assistance to county commissions on public health and authorities and responsibilities. And there's some other resources out there that Nevada Association of Counties has some resources that they've recently had. Dr. Iser's group that I am not going to remember, the Public Health Foundation. I want to make sure he's on here. They have some resources that they're able, and so our biggest thing is we want to bridge those gaps, and we're actively working together. Those 3 partners that are focusing on rural. I know that there's some resources within the state health division. We appreciate our partnership with them, but I think one of the things that everybody should have learned through this pandemic, especially our hospitals, is, you know, we're good at taking care of patients. We're good at doing primary care with our physicians. We really need to, why we were all freshly remembering what we had to deal with COVID. We really need to focus on that public health development in rural Nevada and frontier Nevada. And so there's a lot of resources out there right now, so that as you're looking at these issues, please reach out to us, and we're more than happy to work with you and help you move to the next step, or find resources with some of those other partners that we can tap into.
And
So
then,
these,
yeah,
yeah,
go ahead, Gerald.
Marina. No, so go ahead, Marina. You can.
Okay.
Yeah.
So we're looking at, going through our Nevada revised statute. Our public health laws are pretty antiquated. We're a little nervous about opening them up because we don't want to get things that we, maybe didn't ask for or maybe not quite want, but we are looking at maybe some small changes within NRS to make public health, especially being able to develop health districts, a little more user-friendly, if you will. So we've been looking at that and working with the different counties and partners, and then improving on public health and pandemic preparedness coordination between state and local stakeholders as well. And I think, unless there's anything you want to add there, Gerald, I think that's it.
Yeah, please get a hold of us if you'd like, and we appreciate your attendance at the sessions and our partnership with UNLV and the School of Medicine. And please look for future topics. I know that we're out of time, but I think if you have future topics that you would like to see addressed in this, please reach out to the Project Echo staff. So we'll turn it back to Echo.